As I mentioned at the beginning of this session, that there are cards being circulated. If you have questions, please submit them, and we will move to those shortly. But first off, welcome. First off, consider this a small living room, a chat among friends. What I'd like to do is to first start off with picking up from the video we saw about the 1918 pandemic. And clearly there was a suggestion about 1918, 2018, and then 2118. And one of the core questions I would have 100 years after, are we prepared for a similar event? And I'm gonna ask each of you to comment on that moment briefly, but before we get to that question, what I would like you to do is to first reflect for a moment on the presentation that Harvey provided. Our time's been cut a bit. We have to finish at 12:30. So if we have 3 minutes per person to offer your reflections. Peter, why don't we start with you?
Thank you so much, Dennis. Let me start by really building on Harvey's presentation and talking about what I really think we need from a WHO and from a personal perspective. I think we need an integrated end-to-end global capacity for prediction, for research and development, for preparedness, and for response. And while some of those elements are now in place, certainly more in place than they were previously, the articulations between them are weak, the foundation's fragile, and the context, as Harvey Feinberg described so eloquently, are ever-changing. So what's in place? One of your questions, Dennis, about are we more prepared than previously? We now have a functional overall global events-based surveillance system. WHO and partners now picks up around 5,000 public health signals a month, filters those down to 300, and does full-scale field investigations on around 30. We also have a stronger and more robust response system, led by a 200-plus strong partnership, the Global Outbreak Alert and Response Network. We have much more attention on disease-specific strategies, such as cholera and yellow fever. We have also a really strong emphasis and building momentum around core public health capacities, remembering that until a couple of years ago, the only way we had to assess public health capacities was self-reports from countries. By the end of this year, 100 countries will have done an objective assessment of their public health capacities, which is a critical step in implementation of international health regulations. And finally, the issue of linking research and development. Research is becoming increasingly an integral part of our response. We see now more tools becoming available. We see the advent of partnerships such as CEPI, really trying to decrease the time lag between the development of medical countermeasures and their availability to people that need them most. But the context is changing, Dennis. And two areas I'd really like to highlight in this context are in fact both that Harvey mentioned. One is the issue of urbanization. We've seen the prototype of urban Ebola responses, Ebola outbreaks in West Africa. Now we see yellow fever really challenging us. In DRC and Angola, urban outbreaks last year, this year in Brazil and Nigeria, requiring unprecedented scale yellow fever immunization campaigns in urban areas to respond. But the other issue I'd really like to highlight from Harvey's presentation is the issue of fragile states, conflict-affected countries, the population displacement, and the health system's collapse. We see a tremendous concentration of outbreaks and a confluence with those countries. In fact, 80% of our major outbreaks in recent years have been in those fragile states and fragile contexts. And that really challenges us. It challenges us to detect the outbreaks early, and of course it makes response much more challenging. And you're aware of some of these examples. Polio in Pakistan, Afghanistan, vaccine-derived polio in Syria this year, yellow fever in DRC, the Ebola outbreak on the DRC, Central African Republic border, Niger, the Rift Valley fever outbreak on the Niger-Mali border, and perhaps the prototype of all prototypes, Nigeria and the northern situation with Boko Haram, population displacement, and outbreaks of malaria, meningitis, yellow fever, Lassa fever, and monkeypox. These are the situations of today, the realities of today. So as much as we want to look ahead and focus on 2100, the day-to-day realities must give us that reality check, and we must ask the question, are we fit for purpose today? Technology has a big role, and here we've seen improvements in diagnostics, in vaccines, in therapeutics, in bioinformatics, and of course in data analytics. Certainly diagnostic and multiplex platforms are going to help us. We see tremendous emphasis on vaccine pipelines through CEPI and other partnerships. But at the same time, our investments in resilient veterinary and human health systems need to be as strong as our investments in technology. Otherwise, we will end up, as we have before in public health historically, with a strong pipeline, but an inability to deliver that pipeline to the people that need it most. So in sum, the vision is a fully integrated approach to analysis of the biome, a focus on surveillance of threats at the human-animal interface, an ability to radically characterize new threats, a collective ability to develop and deploy countermeasures through strong veterinary and health systems, especially in fragile states and contexts where they're most needed. Thanks, Dennis.
Peter, thank you.